Hello, welcome to the Dizziness, Balance and Concussion Centre presentation on vestibular migraine. We're looking briefly at what they are and also what we can do to help the dizziness and things like that, and also just some information about migraines as well. So as always, the presentation has been put together with the best intentions, but I am not a migraine expert. I am a vestibular therapist and deal with dizziness. So do please talk to a doctor or a migraine expert about things that you're concerned with. Also, at the time of recording, this is what we think, but it's changing very, very quickly. So again, depending on when you're watching this, bear that in mind as well. Obviously, don't put your healthcare in the hands of a presentation that you see online. Go and speak to an actual professional, and as such, we don't take any liabilities with it. So, what is a migraine? Well, straight away, it's not fully understood. We keep on researching into it. The theories change all the time. At present, we think it's most likely a combination of a vascular and neurological issue, which occurs in people certainly who are prone to it. You get this spreading depression of electrical charge, probably from the midbrain throughout down the cortex. That lights everything up. We also seem to get this neurotransmitters being released, which leads to the dilation of blood vessels, especially around the scalp and areas outside of the brain, and that's where it really becomes quite painful. But also that can start to affect different areas in the vestibular system and things like this, because obviously it's very, very close in proximity. They're looking at this all the time. It will probably end up where someone might be more neurological than vascular or vice versa and things like this. So to say that we may never have this 100% idea, but we're getting more information all the time, thankfully. It's common, and depending which studies you read and look at, it could be up to 1 in 4 women suffer, and women are more likely to suffer migraine, but it's 1 in 4 potentially from some of the research, or 1 in 10 men as well. So it is a common issue, unfortunately. Often a family link, but not always. So some people dismiss it. If you don't say you've got it in your family, they dismiss it. It doesn't have to be. It has to start somewhere, unfortunately. But you do often see it running through families. It can start any time during life. Even young children can have migraines. Very, very young children. So that's also something to bear in mind. But most commonly, we see it starting between the ages of 20 and 40. But if you have a new event anytime in your life and you get this big headache which you're not used to, please go and get it checked out. Please go and see a medical professional. Also, many cases are undiagnosed, and we actually think, and I'll probably come back onto this, that people who get diagnosed with things like sinusitis and things like this, actually it could be migraine. And there's the way it presents, and you'll see going throughout, you can see why it gets undiagnosed as well, and it's probably a lot bigger problem than we realise. The technical diagnosis from the International Classification of Headache Disorders in their 3rd edition is this criteria now. We're looking at it that the headache has to last between 4 and 72 hours, that it has to be unilateral, so just on one side of the head, a pulsating quality to it, moderate to severe pain intensity, physical activity making it worse, and then you need to have some vomiting, nausea, or fear, issues with light or sound, not fear as such, but issues with them. I think this whole classification is probably summed up by the last line there in the E. It's not better accounted for by any other diagnosis that they've got. We'll see why with this diagnosis. I'm the biggest fan of it because I think it leaves a lot out. And that's where this comes in. So it's not just about a headache. You can have a migraine without a headache at all, a silent migraine, which again is a surprise to a lot of people. You can have headaches and migraines without the aura, which again becomes a real surprise to people and things like this. So it throws open why things are misdiagnosed as well, and that becomes a big issue. But you can have lots of different symptoms with it. The sensitivity to light, the sensitivity to sound, the nausea, the vomiting, things like this, which are quite common. But a lot of people can have balance loss, the mental confusion, disoriented, issues speaking at that time or even before, visual issues, so they can't really track things as well. Weakness in limbs, and again back to that sinus pressure rate, can be that, and similar things, other things that aren't listed there, fullness in the ears and things like this as well. So lots of different things can be affected that aren't the most common that you think about with a migraine. We often think, oh, severe headache, severe aura and things like this. actually the symptoms are quite wide ranging, unfortunately. The other thing is how long it can all last for, and the next slide I'll come on to this a little bit more as well. But you've got what they call a prodrome, so a precursor to a migraine, which for some people can start days before the actual event. They may be able to prevent the event coming on, the actual migraine coming on, if they can recognise it. Sometimes not. But that can last days before. Then you've got the migrainous event, and then you've got what they call is the post-drome period as well, where a lot of people describe it as being a feeling of hungover and things like this. Is again very individual to different people, but again that can last up to 2 days. So you're talking about an event that the next slide will illustrate, which can last a significant amount of time. What I really get involved with these is when the migraines are causing dizziness. That can be directly at the time, or it can lead to different sensitivities and visual sensitivities afterwards, or movement sensitivities afterwards. So a lot of people will have dizziness with a vestibular migraine. They'll either have the dizziness at the attack, but they're often left with issues as well. And that becomes an issue, and that's where both of those I start to treat and look at. So the timeline of a migraine attack, this was off the American Migraine Foundation, which seemed to sum it up quite nicely, is how you're starting with the prodrome and then working all the way through to the postdrome. Now, if you take worst case scenario for all of these, you're talking a few days for the prodrome, you're talking potentially 2-3 days for the actual headache, and then you're talking for another 2 days for the postdrome. So you're talking the best part of a week potentially in the worst case scenario for this attack to have gone through and worked through, which is pretty bad. The thing is that you look at the different symptoms you can have at the different times as well, and again this can differ for everybody. It becomes pretty debilitating, and certainly these triggers, certainly when we look at dizziness and balance as well, that means that for a good while you can be out of whack, and then it leaves you with susceptibilities thereafter as well. So it's quite a big problem, unfortunately. So how do we treat it? And that's when we look at with vestibular migraine, and this is why I've got an interest in migraine, is that whenever I get someone sat in front of me and we've got that diagnosis, we need to look at it twofold really. Obviously I'll be looking at the dizziness as well, but I'll always talk to my clients and patients about how are they managing their migraine, and have they been able to manage it and figure it out, because that's the first step. If we can stop the migrainous events or limit them or reduce them, that's going to be helpful for everybody. It's not as easy as it sounds, and as I say, I'm not a migraine specialist and things. Not all doctors or neurologists are either, unfortunately. So trying to find someone who's got some real specialist training in migraines is can be really beneficial. So do try and do that. But the biggest advice I've always seen, I've always been given by people I've spoke to or read, and I give is you've got to try and figure out what your triggers are. Now, it's easier said than done. I've had patients literally keeping reams and reams of diaries and everything noted down and driving themselves crazy, and in the end they've not really been able to figure it out. There are some common ones, obviously the stress, the anxiety, there's food related ones which can change for everyone. The alcohol, the caffeine one is interesting because we've got to stick chocolate in there as well with that. Dehydration is a very common one, and changes in the weather patterning, unfortunately, which we can't really affect unless you want to move somewhere else, but that becomes quite an extreme one, but I have known it happen. Hormonal fluctuations is another common one. That's why we often think that women are more afflicted by this than males. Fatigue and medications, and that becomes an issue with your medications, and that again, having a good review by a pharmacist or someone who's with knowledge of all of this can be helpful. The problem with triggers as well is that it might be a combination of them. It might be that when you are stressed and you are eating certain foods, or when you are stressed and you are dehydrated, that combination together, or when you are stressed and you have a loss of sleep, that's what triggers the migraine, rather than it being just one instant or one actual trigger on its own. It might be a combination, or it might change a little bit as well. So it becomes, we say it flippantly, oh, you've got to figure out what your triggers are. I appreciate it's a lot harder than it sounds, but we do need to keep on trying to find that. When I talk about medications, though, the medications for managing migraines is improving all the time, and there's different ones which are coming to market, and certainly over in the States it's quite active at present, where there are new medications, one to help with an attack, and two to be taken to try and prevent attacks, and especially if you're getting hit by many headache days a month, that might be something that you need. So the medications thankfully are improving all the time. The key is to keep up to date with that, and also at times go and have a chat with your doctor about it. If they don't know about them, direct them to a resource which does, and things like this, and they can look into it. Other things that we do try and got some decent research behind as well are, there's a machine called a Kefli machine. I have no links with the company at all or anything like that, so please, I'm not trying to promote them in any way, shape or form, but the product that they've got is a good example of it. And it's just the kind of like a TENS machine on your forehead and things like this, which has been shown to, one, help again at the time of an attack, but also used in a different way can help prevent attacks coming on, we believe, by stimulating the nerves there. The other one is a magnetic pulse, single pulse, through the back of the head. That's very, very quick and things like this, and we think again it disrupts the different electrical signals and things like this going through the brain, which we think can be helpful as well. Other thing that a lot of people don't realise, that certainly, and it's only for chronic migraine sufferers, but Botox is a potential treatment to try and limit it. Again, it might not help everybody, and all of these different treatments and preventative measures might not help everybody, unfortunately. That's the hard thing. So again, trying to find what works for you is important, and doing that, but doing that in the right way, because if you change everything or try everything at the same time, you don't know which one's helping. So it's trying to have a kind of logical and organised approach to it all. So I've gone about migraines, the dizziness and the vertigo. So often the biggest issue with this is someone will have a migraine event and then they're left with issues afterwards, and they're left with dizziness or vertigo there afterwards, or they're left with just really feeling unbalanced, disequilibrium and things like this. They're going to probably be left with some other issues with the neck or the jaw, just from anxiety and tightness and things like this, which has just tightened the whole area up and things like this. So that, and again, that can become a vicious circle, because that can lead to more migraines and things. For a lot of people, the symptoms will wax and wane over time, so they might actually think, oh no, this is getting a lot better, when actually then it starts to come back a bit more. So that's quite a difficult one, and quite hard to fully identify and keep an eye on, because people think they're getting better, they stop doing the different exercise things, and actually they're not, or they've not improved to where they want to do, and the different times of the month and things will change that. So we've got to always bear that in mind. Often it's visual or movement evoked dizziness, vertigo, but people, and certainly with the proximity to, with all of this happening to the vestibular apparatus, it can set off a true BPPV as well in a lot of people, and giving them the true vertigo and things like this. So we need to do the crystal repositioning maneuvers and things like that, and then obviously there's the balance issues and things like this. What I'm involved in and what we do and what can really help, and the research has shown it can help as well. So we would look at what's happening with your vestibular ocular system, seeing if there are any triggers there, seeing if there's any deficits there, and then again treat accordingly on what we find. Looking at just general motion sensitivities, and often you'll find a lot of these come together. It's not purely the motion, it's often the motion with a visual input as well and things like this. So being a passenger in a car can be awful for people and things like that. So it's we've got to look at it. We can't just isolate it and put it in one box. We've got to be open that it might be more than one thing. Looking at the different balance and issues there, disequilibrium issues there, very important to look at that with your eyes open. But a lot of people might not realise at first actually how bad they are when they've got their eyes closed. Now, we don't walk around with our eyes closed, thankfully, but that would mimic if someone's struggling, say, walking in dimly lit places, things like this, or at night getting up to go to the toilet, things like that. So we need to look at those things as well, and then again treat appropriately. The best way to be looking for a BPPV is we put you in goggles and record what your eyes are doing, so they work very well, and then we can start to fully find out which canal is at threat, which canal is the problem, and then again we can address that in the way it should be addressed, rather than just trying to guess and things like this. We can really get on top of it and hopefully get on top of that one very quickly. And then also we'd look at the neck and the jaw and things there, because again, whenever a migrainous event happens, it's not purely the physical side of it. I've not spoken about the psychological side of it and things, and the stresses that it causes, the changes to lifestyle, the stress it can put on relationships, work and things like this. All of that unfortunately can have a physical outcome as well. So a lot of people might clench the jaw or tighten up around the neck as well. So we look at all of those things, and we need to look at it all. So it might be that someone has pretty much all of these things. It might be that they have one or two of these things. That's fine. And that's where a lot of people always ask me, what can I do? Well, it depends on what we find, and that's the key thing, is that any program you're going through should be tailored to yourself and very individual to yourself. Your circumstances are going to be very different to somebody else's, and that's, we need to address those and make sure it is. So if I've got a farmer who's looking after animals and things like this, that might become an issue for them, so I need to look at those sorts of things. Whereas if I've got a ballet dancer, or if I've got an office worker, or whatever it is, I've got to be able to address it to them. And that's the key thing, is that it's not a one size fits all. We need to find out where your issues lie and target those, and that's how we get you better quicker as well. It can take time as it is anyway, but that's what the quickest time we've got, and the faster that we can get results, is by tailoring it to yourself. So we need to look at that. So thank you very much for watching. It's kind of only a brief touch on the subject. If you are suffering or you've got any other questions, please do get in touch. You can go to the website dizziness.therapy.co.uk, or just get in touch via email, info@dizziness.therapy.co.uk. I'll always try and help if I can, or try and guide you in the right direction. Some other great resources for migraine, migraineagain.com, that's one over in the States. That's a lot of good practical advice and help and things like this, and it's quite good at keeping up to date with the new releases on medications and things like this. And the Migraine Trust as well, a UK organisation, really good as well. And thankfully, with all of these things, they are trying to find even better products to try and help people both prevent and treat as well. But thank you very much. I say, if you've got any questions, please get in touch. Thank you.